So welcome everyone to our Workforce Transformation Breakout. We're going to try and make this as interactive as we can, to be honest with you. This is really to be about the discussion that we can have around all of the challenges that, we had an aspiration set to us this morning around some of the stories that we've heard about how you can really transform the healthcare system. And a key enabler of this is transforming the workforce, which we all know. So what we wanted to talk about in this breakout is really how do we think about some of the challenges, but also some of the key actions that we can take to help us transform the workforce and really enable those transformations, because they're not going to happen unless we can do that. So in order to try and understand your perspectives on this and make this a bit more interactive, we wanted to start off with an exercise to just sort of generate some thinking and help us understand how we focus the discussion. We are then going to hear from Judy Screeton and Liz Pace, our two expert speakers who I'll introduce when they're coming on, who'll bring some of their perspectives, and then we really want to bring that together for discussion at the end. So if I could ask you to just turn to your neighbour and take the next sort of 5 to 10 minutes to talk about what are the most significant workforce challenges that you are facing in your organisation. What do you think are the biggest workforce challenges facing the NHS in London today, so at a bit more macro level? And what, if any, action should we be taking collectively in London or nationally to address these challenges? And then what I'll ask you to do is each pair to just play back the most significant challenge that you see, the one most significant challenge that you align on, and the action that you think is most important. Okay? I'll just give you 5-10 minutes to have that. So I think that's 5 minutes.
It's good.
I can hear people are still keen to keep talking, but if I could ask you to just, if one person from each of the groups could just tell us what do you think is the biggest challenge, and what is the action that you think is most important to take?
So we picked up on the doing things differently in Carrie Ann's Trust, and the fact that most people think that means losing posts. Yeah. I think Lily wrote a column recently about what real innovation is, and a lot of it is not just about cutting costs, and also attracting those people who really need to change, the people who come to the workshops and engage with the programmes, and perhaps those people who have already bought into it. Yeah. And how do you get those in? So we didn't actually get on to the action, did we? Did you suggest, have you got action off the top of your head?
I think we might have to force that discussion at the end so we don't just focus on the challenges. Great, thank you.
So we answered all three, but they all looked rather similar, really. So the first one was around actually GPs and primary care nurses, which is a huge piece. Lots of retiring people, lots of people getting fed up with their PMS contract that's about to change. I won't go into the rest of it. There's also something for us about the integration workforce, which is different to what we have now and how we work with that. So that answers kind of 1 and 2. But we also think in 2/3, there's also the consultant numbers. So how do we do that? Because we know with the London Quality Standards, we need more consultant level people as well. And then we really want to answer this question maybe across London, which is how do we put that training together? It's a bit, Anne, the same as yours, the training for the new workforce.
Very helpful, thank you.
So I don't think we came up with anything very different. On the last one, though, we think that one of the priorities we really do have to address is the training practice nurses. Because if we're actually going to deliver any changes in London, we've got to do something about what is a workforce that we're doing no national or local training for.
Yep. Thank you.
We focused on mental health, and we talked about some of the very innovative roles that have been developed within mental health, and particularly how psychological therapies have been stratified, and how actually that's an example of a quite a stratified workforce as well. But the importance of the governance arrangements around that, especially when you're working with non-registered professionals. We also talked about the kind of notion of cost and making sure that there's value for money. So it may look like it's slightly cheaper, but actually it depends on whether if that person's not registered, then actually they may not actually be able to deliver the same kind of output as somebody who is.
Thank you, very helpful.
I think that was it.
Thanks. I think it was very similar as regards to the mental health, and also as regards other aspects that other people have discussed. A couple of things that I just wanted to bring up. There was a discussion about the quality of the nurses in recruitment within mental health themselves. which then leads on to the issue around practice nurses and actually looking at them as regards what their role is going to be like over the course of the next 2 to 5 years compared to what their role has been historically up until now. From a CCG perspective, it's around my challenges would be around how we start looking at truly integrating workforce across CCGs and local authority, plus between CCGs, local authorities and other CCG and local authorities as well, because obviously with cost reductions in management, we're going to have to start looking at that. And very lastly, when we're talking about training, I think that we've got two aspects of training. One is immediate future and one is future. The training for the immediate future is around getting people to have a different culture and a different view about how they see their job role developing over the course of the next 2 years. So, for example, consultants being very aware that they're going to be doing much more MDT stuff, much more out in the community stuff, and for the future roles, actually having that integrated within their training programs. So at the beginning, they don't see themselves as isolated specialists within a secondary care setting or an isolated GP within a 9 to 5 working day. That there's got to be some way of being able to
We
expand
have to embed the changes in
That's
the training. Great, thank you.
I think we talked about all the things that have been covered, but just to reiterate, because it seems to have come up in every group, we talked about practice nurses, we talked about the numbers thing, the age and the profile, retiring GPs and nurses who seem to have been retiring ever since I started practicing, really, but we've always been told about the district nurse gap. We're having a real problem recruiting nurses into our local acute trust, running at about 15% vacancy at the moment. We also talked, I might have to hand over to Ruth at this point, we talked about the risk, I think, with local authorities and health visitor commissioning. Do you want to say any more about that?
I do public health, so I'm based in a local authority. And I suppose one of the issues is about integration of skills and recognition of skills, so it's not a general job. And I think the other thing that struck me very much in the presentation was about time for patients. And there's something about sort of the theory and the reality, when in practice lots of these are quite high pressure.
Yeah, absolutely. Thank you. And the last group?
We talked about certainly the challenge of making mental health an attractive career and attracting people to some of the outer London boroughs, where, you know, perhaps, and also echoing some of the concerns about the quality of mental health nurses coming out of training. Other issues were really trying to look at career pathways, transferable skills, perhaps more core training before specialising, to allow people to come out of their professional tribes and be able to work in multidisciplinary teams going forward. Certainly more request for mental health training for medical careers to be a large part, otherwise we won't be able to integrate as we go forward. And also, I think, being more clear about a London-wide training strategy for the future and what our part is for all of us, what we need to be doing at local level to contribute to an overarching training strategy so that we know we will have within London the component of transferable skills we need wherever people are going to be in 5 years' time.
Yeah, that's really, really helpful. Thank you all. And as we can hear, lots of common themes here, as we would have expected. Particularly, I hear this point around how do we transform and help support the existing workforce to transform and understand their roles in the new systems and the skills they need to have. I heard that across the board, but with a particular emphasis on the challenge in nursing and practice nursing in primary care in particular, but also strong themes about mental health. And one of the challenges here is that we've been increasingly moving towards specialism in the health system, and part of the challenge of the new model is that actually breaks some of that down. So how do we help people to culturally understand that what we're trying to do and have the right skills to do that. So I heard that we need to support people through the transition, including things like having the change champions. How do we think about the immediate training needs to help people actually fulfill these roles? and ensure that we have the right governance around that as well. But I also heard the need to embed this in a broader, longer term training strategy so that we're actually training people so that they're fit for, the people who are coming out of our training programs are slotting into the new world effortlessly, and we're not reinforcing all of the old habits through the training, the legacy training. And I did hear one thing about, I think, assuaging the concerns of people who are worried about losing their jobs, because as soon as they hear the words workforce strategy, and particularly in the light of the economic conditions, they think this is all about, sort of downgrading roles, losing your job. And so how do we help people to understand what we're trying to do and make sure that we don't get fooled as well by the value versus price challenge? So great. We are going to move on now and actually hear from our speakers. So I think that's a great context, and I think that Liz and Julie were particularly keen to hear this so they could weave this through their presentations. Julie's going to talk to us first. Julie Screeton is the MD of the Health Education for South London. She has had a long career in workforce in the NHS. She was in the Workforce Strategy Directorate in NHS London with Anne back in the days, and has had a number of HR director roles in the NHS. So she's going to share her perspectives on the workforce challenges at a more macro level, and then we're going to hear from Liz, who will delve a bit more into some of the examples she's been working on, and then we'll open up for discussion. Julie.
Thanks, Sorka. And I think what I'm going to do is ditch the presentation, because I think the conversation that we've had is really what people are interested in talking about, apart from the kind of future supply of GPs, is things about today's workforce and how we can make today's workforce fit for purpose to deliver the new models of care we've been speaking about. The only slide I'll put up, really, if this works, is just a bit of background stuff that reminds us about where we've been in terms of the shape and the size of the NHS workforce since 2002. So we have seen a phenomenal growth in some parts of the NHS workforce. Colleagues mentioned consultants as part of the feedback to their conversations about the need to grow that even more. Practically, we have had a massive expansion. Can we afford further expansion? And we're talking about GP expansion. And we know that GPs cost about 3 times the amount to train as a straightforward secondary care clinician. So against that backdrop, the conversation we've had is very much about today's workforce and taking the people that have been on stream since 2002, who will be with us for many years to come. I think it's about 60 or 70% of today's workforce will be here in 10 years' time. What can we do collectively to sort that out, to make those people fit for purpose? So I'm not going to talk about any more slides than that, because I think otherwise I'd lose you and you'd think, what is she talking about? What I would say is the Local Education and Training Board model that's been in place since the 1st of April 2013 is supposed to address the very conversations that we've just been having. So we have 3 local education and training boards in London, configured around the academic health science networks in London, created from the bottom up as following the will of employers and commissioners at the time. So theoretically, we have a fantastic opportunity to use those networks of people that represent many of you. And I think, Ruth, you're joining Health Education South London Board from the 1st of April. So a collection of people who come together and govern the expenditure of just over £1 billion of education and training money in London. So that mechanism is in place. I wonder if many of you are engaged with that mechanism, because that is the place where the conversation should be having. And you should be shaping the investment as employers and commissioners in the very things that you've described. So I think what I would just say around what LETBs have done since they were created is, now we are 3 separate creatures, inevitably. We have 3 separate complexions, but we operate on a hub that does things broadly in similar ways across many kind of large-scale transactional things. So it should feel we have 3 very different front ends running on a very efficient back office. At least that's what we tell Health Education England anyway. But what we have all done since we were created is invest more in continuing professional development. So between us, it's about 60 or 70 million we've put into CPD and strategic workforce transformation since we came into being. You should be feeling that change. We have all invested in primary care on the same per capita basis as we have done in secondary care. And some of us in South London, we've focused particularly on the hospice movement, where we see massive years of underinvestment, but actually highly efficient ways of working, role definitions, and the delivery of education and training out to the broader NHS. So you should be feeling some of that change. What we've all also done is come around this concept of federated provider networks of education and training delivery. So we call them community education provider networks. The concept is that we can come together around the model of federated general practice as a place to bring employers together, as a place to deliver education and training. The concept is that education and training should be delivered in the place where patients will be delivering receiving care, not in secondary care, and the vast majority of education and training takes place in secondary care. And anecdotally, if you're in a South London university as a nurse trainee and you want to go to general practice, you have to organise it yourself. How can this be sensible? So all of us are trying to build capacity and capability in primary care education. So there are some things that we're putting in place to put bedrock and support of things that we can help deliver workforce transformation to facilitate you doing it. We've got the education provider network model. We've got you sitting around the table, and I'm not sure from the conversations whether people here are feeling empowered by that model and what more we need to be doing to get you involved in the discussions and decisions that your LEPB is taking in your local area on your behalf, because this is very much about devolved resources. You talked about a London-wide strategy. Every LEPB in England was required to produce a 5-year skills development strategy that were written very much in a bottom-up way as part of our authorisation to be LEPB. So across the country there are 13 5-year education and training strategies, and NHS Health Education England, that's a Freudian slip. Health Education England is in the process of producing its own 15-year strategy that will reflect some of the stuff that's happened locally. But it sounds like from that conversation, is that hitting you? Is that something you feel you've made a contribution to? And what more should we be doing to make those strategies more live and real for you? And finally, I would just say on mental health, which was a topic of discussion. Across London, we're increasing commissions of mental health nursing. South London more so than colleagues north of the river. We're all in conversation around the dual qualification, dual registration approach to mental health nursing, with some of our colleagues, SLAM in particular, quite interested in taking this point forward. And on the quality of mental health nursing, and I think new qualified nursing generally, we are seeing massive improvements in terms of that. We had a situation not that long ago where all of our employers are running aptitude tests for newly qualified nurses coming out of universities. And employers, of course, are signing people off as competent to qualify as nurses. So how can it be that you sign someone off as competent and then don't even shortlist them for a job? So we had some really good conversations through the LEPBs and the local stakeholder engagement we've got to really fix that, because that's a crazy way of investing a shed load of money, about 300 million a year, and not even employing the output of those investments. So that's all I'd say, just a bit of a response about what we're doing, a bit of a provocation to you about what can you get more out of your local LEPB, but also to give you some assurance that things are in train, but we are very keen to get more traction with you to help you realise the kind of real problems that you're facing and investing in a way that helps you to do that.
Thank you, Julie.
You should hear from Liz. Sorry,
No, that's
probably
great.
would have taken my time.
Thank you very much, Julie. I'm going to hand over to Liz.
I want to leave that slide on there for
okay.
a moment.
We'll hold questions until the end, if that's okay.
Well, I thought so. We have the two presentations and then questions together. Is that all right?
Yep, absolutely.
I wanted to leave that slide on. My name's Elizabeth Pace, Liz Pace for short, and I am, first of all, a rheumatologist. Secondly, I was postgraduate dean in London for many years, and now I'm chair of the North West London Integrated Care Programme, as well as NED for a foundation trust. What I wanted to show you there was what's happened in the last 3 years, if you look at that. And we've got this planned expansion of consultants. We can have a consultant-delivered service. That's lovely. But what about the AHPs? What about the drop and registered nurses? Do you know that that is almost entirely Band 7 and 8, almost entirely? It's 11% drop in Band 8 nursing staff since 2010. Whose plan was that? I thought we said we needed more leadership. Mm-hmm. How can that be? How can that be? How can we recruit and retain passionate, intelligent, driven nurses when that's the future they're looking at? One other thing, I was thrilled to bits to be invited today to London Leaders. Hey, that is really, really great. And I looked around the room and all these, did you feel that? I'm a London Leader, that's terrific. But did you notice anything about the people who are in this room today? Anyone notice it? I noticed how many women there were. I thought, that's terrific.
It doesn't reflect London's population, does it?
45% BME. Where's 45% BME in this room today? You know, there's something wrong. We're not we're not using the pool of talent in London properly when we get that kind of disparity, when we get that kind of limitation of ambition by the way in which we organize our workforce. I know it costs money, but there's something wrong about that. The consultant and the nurse difference there's something wrong about that. So I'll go through to, I had some things I wanted to say that I think are relevant to what that we were talking about earlier. When you look at what goes wrong, and there's a nice study by Walsh back in the BMJ of 2002, even before the recent reports. Same thing, poor communication, disempowerment of staff and patients, ineffective systems and processes, isolation, and inadequate leadership and management. We didn't need the Berwick report and the Francis report and the Keogh. We really didn't. We knew all that stuff. We keep finding out the same things. Well, what can we do a bit differently so that the staff we have deliver the care that the people we serve deserve? So that takes us to integrated care, and how do we develop a staff for integrated care? And it's all about putting patients at the center, empowered and informed. That's what we've heard all morning. It's about professional services and organization working together. It's about being proactive, assessing risk, intervening earlier, everybody working to that vision of better care, people able to do more for themselves. So when you look at that study, I don't know if you read it, but it makes good reading, that was done back in December 2012 about integrated care, 16 pilots, and what they said was the importance, there you go again, strong leadership, relationships at a personal level across organization, shared values and vision, widespread staff engagement, education and training of staff. It's so much of that's just about the workforce. We won't get integrated care unless it's led by patients who make it clear what it is that they need and want, supported by staff at every level, including the front line, in every setting of care. It's got to be a social movement or it's not going to work. So it shouldn't be as hard as this, and it's because we haven't really trained people to work together in the way they need to do. We did a study, got the clinical educators from across London talking about what they thought their staff needed to be prepared to work in integrated care. And this is what they came up with. It's hard to work with patients who feel empowered. It's kind of, it takes some work to move from having the power to giving it over. It's hard to work with other professionals until you recognize the roles and the expertise they have. And these things about respecting data, collecting metrics, about communicating, about taking responsibility, and being proactive, innovating, all of this are absolutely crucial. So how do we do it? Well, these are some of the ways we've tried in Northwest London to try and get that learning across to the staff that we've already got. A little bit different from sending people off on courses, but secondments, paired learning, a lot of success in putting people together, managers and doctors, but also people who work in hospital and people who work in practice, a number of sort of paired learning pilots. Coaching and motivational interviewing. Doctors need to learn those skills. They're not very good at it. They're better at telling than at asking. The multidisciplinary case conferences in the MDG has been hugely beneficial, but only to the small number of people who go to them. We need to spread that learning out. Action learning sets, but also a better understanding of the patient experience. And just to finish off, I want to tell you about something we've been doing with Imperial, which has been really interesting. And that is simulating, acting out the patient's journey in front of a group of staff and patients together. This is an actress who is simulating being a teenage girl who gets an asthmatic attack in school. I just want to show you the rapt attention being paid by the young doctors as they watch this thing play out in front of them. And suggests that this kind of learning through theatre, if you like, gives people an opportunity to have one single frame of reference as they see a patient pathway unfold before them. And it gives them the opportunity to be challenged but not panicked by the reality of this frightening situation they're dealing with. And it has been extremely successful as a way of bringing patients, staff from various sources. Yesterday we had a terrific day with GP receptionists playing out. You can see in the background the various scenes that we use to simulate the journey of an elderly patient going from pillar to post, and the discussion that then takes place, and then the suggestions that are made about how you could improve that journey, and then finally the rerunning of the scenario with all the improvements that have been suggested by the people sat round the room being played out again in front of them. I tell you, it's a mind-blowing experience watching people suddenly get it. As one of the receptionists said, I've never really seen the whole picture before. It's been extremely successful. And the week before we did it with high street pharmacists. It's, I think, just one example of the way in which we have to change the way we train to reflect what it is that we're trying to do. Because the patient's journey cuts across the production lines which each of the groups of staff have developed and are working on making more and more efficient. And so that's what I wanted to share with you as a way of introducing empathy, compassion, understanding of the big picture to the staff who will have to make these big ideas work, or else they will end up being an obstacle to what we're trying to achieve in integrated care.
Yeah. Thank you, Liz. That's really, really great, very inspirational. And it really reflects all that we know about how adults learn as well, right? Through, because experiential learning is so much more powerful than sort of the traditional lecturing that we're all used to from college. So I wanted to open up now to two things. One is to questions from for both Julie and Liz, and if possible, I'd love to bring together what Julie and Liz just said, because we had sort of the perspective from the Let Be's around, you know, what they're trying to do to deliver against some of the challenges that you laid out, and also then some of the more innovative ideas that are coming out of the ICP to try and help bring people through this transition, which is difficult, and understand their role in that. So if you have any questions on particular points for either Julie or Liz, then maybe we could open the discussion to think about how we bring this together.
A question, but a discussion point really, given that what we really want is kindness and compassion. How do we train for that?
Well, that was one of the points that came across yesterday with the GP receptionist, which was having seeing it in front of them and empathizing with the actor made them see things differently, because otherwise what you do, you protect yourself. I mean, that's the first thing that goes with being overloaded is emotional engagement, because you have to protect yourself from it. Here's an opportunity to engage without risk, if you like, because you are able to open up without feeling overwhelmed by the panic of a room full of people all clamoring for your attention. And so it helped put people back in touch with the reasons why they went into what they were doing. And I have to say, you know, that the patients who were in the room, because I don't do anything now without patients in the room, the patients in the room said, where are all the dragons that I usually have to deal with? This is a room full of gorgeous people. And of course, that's what's out there, is a whole workforce of lovely people who want to be in healthcare, turned into people without compassion by the stresses and strains we put them under, I think.
It's terrific. I'm just reflecting, and Beth, you remember this, on some of the work we did with GP receptionists in the access work, and there was two parts to it. One was actually helping them step back from sort of, you know, this terrible stress they were under. If you've got queues outside the door every time you arrive at 9 o'clock in the morning and people shouting at you, I mean, just awful. I don't know how they do it. to listen to patient stories. So that was the most powerful way of actually sort of making the mindset shift, which we talked about a lot in terms of the challenges. Really important to follow that up then with the tools that enable them, the sort of the functional tools that enable them to do that, because as soon as you sort of slip back in, you've still got all of the stresses. So even though you want to be sort of the empathetic person, you have to have the tools to enable you to deal with that.
Probably just worth saying something else that we're doing is moving the universities to a situation of recruiting for values. So I know that's not dealing with today's workforce, but all of our universities are required to recruit against a kind of set of values. There's different techniques for selecting people onto programs, which are based on multiple mini interviews and assessing them in real situations. The same certainly with general practice recruitment. So we're starting at the feeding end. We need to do something about protecting compassion.
I suspect most people who go into healthcare have those values. I think we drive them out of them the way we employ.
Well, we worry about the free degree for nursing and actually what kind of people are going to be attracted into nursing when it's a free degree. So only 3 years' time we'll be able to tell the answer to that one.
There's a question, comment here. Ursula, do you have the microphone? Oh, sorry. Oh, I'm so sorry. Sorry.
My comment was that we were talking a lot about the integrated care and the changes. I think the workforce elements are by far the biggest component that will run through all the way through. And the timelines, I worry about the timelines that people are talking about in some of the programs that have been talked about, because it doesn't allow for the change process for the staff associated with it. And we know that a portion of those will get it quite quickly, some will come along slowly, and we will definitely be left with the recalcitrants that really don't get it. And it's not a 2-minute job, this. It's a very long-term job with lots of time out as well for people making those changes and having times and away time. And there is ensuring that there's some of the budgets there to enable some of that time before the changes, time to work it through and moving that through. And unless we've got a really good OD schedule and development programme associated with it, we won't get from A to B. And even with that, it's going to take longer than it takes to move the kind of the pieces around.
Just time for one more question. I've just been told that we're getting very close to our time, so we will need to wrap up soon, unfortunately. But
I mean, the thing that strikes me is that we're all concerned about how our current workforce is doing and the impact of doing the jobs on them. And it feels to me a bit as if training is quite a long way off, and whether we need to do something that's the other way round. So we need to, in terms of enabling them to change, we need to put the resource in. I don't know whether I'm talking about apprenticeship or I don't know, some sort of system where the capacity creates the ability to change, and then people could then go on and do some other kind of qualification. Because otherwise it feels like the gap isn't about what people know, it's about their ability to deliver it in an environment like that.
That's right, and people need some time to process their emotions, to recognise them. The concept, I mean, one of the things that the GPs say who are on the multidisciplinary groups, that to have a half day once a month where they get together with colleagues and talk about patients but aren't actually delivering work is, it's a big opportunity just to process and think. And we've kind of, in our drive for these production lines, we've tried to write out all the slack, which that's the slack during which we get in touch with our compassion and our innovation and so forth. A mistake.
I'm going to wrap us up here because I think we are out of time. But I think my takeaway from this is there is a really big challenge here, which we all articulated at the beginning around workforce, if we're going to enable this transformation. And it is key that we address it. Because if we don't, transforming the behaviours of the people on the ground is what's going to make this work or not, frankly. And I think that was actually reflected in some of the speeches that we heard earlier on. What I take away from this is that there is a lot that we can learn. So there's lots of thinking going on around how you can do this innovatively. And there is a lot of resources, as Julie was saying, that are dedicated towards this. But it feels that there really needs to be some thinking around how are we going to manage this in the transition so that even if we won't get to perfection, right? We won't transform everyone. But how do we tackle the biggest issues of the transition now? Using some of these techniques that we've heard today and using some of the resources that we know are there, and also start planning for the longer term so that we don't end up in a situation where the people who are coming out of the universities are not able to fit into the system as we now have it. So thank you very much for sharing your time and thoughts. And I will let you go off and go to your next breakout. Thank you.